Good afternoon, everyone, and welcome to this meeting of the Audit and Performance Committee of the Perth and Kinross Integration Joint Board. We'll just start by asking if there are any apologies for the meeting.
Yep, we've had apologies from Professor Nick Beach, Bernie Campbell and Jim Fowlis.
And for the start of the meeting, Councillor Stewart will be substituting for Mrs. Beth Stewart. Correct? Thank you. Can I ask if there are any declarations of interest in relation to items on the agenda today? Okay, thank you. So if we move now on to the minutes of the previous meeting, can I ask if there are any issues with the minutes from the previous meeting, which was held on the 30th of November? I just had one which I raised in pre-agenda as well, which I just noticed hadn't been included, which was under 5.2, that we also agreed following the discussion about the Perth prison inspection that the risk register would come back to each meeting of the Audit and Performance Committee and that officers would make us aware of any exceptions to that, which has been included in the report specifically on risk management, which we'll have later, but I just thought for the accuracy of the record that we ensure that that's updated as an additional resolution. Okay, with that addition, are we happy to approve the minutes from that meeting on the 30th of November? Yes. Okay, thank you. If we now move on to the action point update, Mrs. Smith, do you want to walk through those, please, for us?
Thank you, Chair. The first action around governance and accountability arrangements, we have, through the workshops that we've held in November, enhanced the learning and understanding, I think, both of the management team and of our IGB member and colleagues, significant understanding of governance. However, I think what we've agreed is that in order to support that understanding further, a one page, if we can get it on one page, governance framework that articulates the roots of assurance and governance responsibilities in a succinct way that can be used to support all of our discussions, both internally and with external stakeholders. And that's something that we're currently working on and hope to have completed by the end of March. In terms of training and development of IGB members, members of my team have met with our Vice Chair to have a detailed look at, in particular, the induction training for our members, and there is a further meeting planned to take that forward with I think a step change in how we will take forward induction to very much include both training from members themselves, but also from officers themselves, but also from members of the IJB, and take it forward in that dual way to get the benefits of both. In terms of action point 4, the Transforming Governance Action Plan is on the agenda today, and in terms of the final action note, the issue of the risk sharing agreement has been outstanding for some time, and at the IGB meeting last Friday, the IGB formally requested that Perth and Kinross Council and NHST side look to review and finalise risk sharing agreements and provide clarity to the IGB.
Thank you very much. Can I ask if there are any matters arising in relation to the minutes of the previous meeting, or any questions on the action point update that Mrs. Smith has just outlined? No? Okay. Thank you very much. Now, if we move on to item 4, which covers performance, as I spoke about at the IGB, as part of our refresh of the terms of reference, and an understanding that perhaps in the past the Audit and Performance Committee had not been focusing to the extent that it could on the performance side of the IGB, which as an organisation that is primarily to deliver public services, that's very important. And the first item that we'll now be bringing forward is the first corporate performance report, which is item 4.1. we have, in the updated terms of reference, clarified that responsibility of oversight for the statutory functions such as complaints handling, freedom of information requests and participation requests will now be overseen by this Audit and Performance Committee. This is the first report of this kind, so in addition to any questions that people have on this report today, I would like to ask that if any members have any comments on the format of the report, which might help officers and ourselves provide the information that this committee needs in future to scrutinise the corporate performance of the Integration Joint Board, then those questions would be very welcome. So I'll pass over to, I think, Mr. Packham first to introduce this report. Thank you.
Thank you, Chair. Yes, we're very pleased to be able to bring this forward, and I'm delighted to have my colleagues Evelyn Devine and Paul Henderson, who's substituting for Diane Fraser today, to take the committee through the substance of the report. So without any more ado, I'd just like to hand to them. So thank you very much.
Okay, I'm just going to take you through the performance indicators that initially relate to the complaints handling procedure. To put it into perspective, we have 3 complaint handling procedures. We have an NHS Tayside procedure, an IJB procedure and a Perth and Kinross Council procedure. So the first indicators you're going to look at are the health indicators in relation to complaints. I would say at this stage that these are complaints that are received by for the delegated services and not for the hosted services. So there will be further work to be done around the complaint handling for hosted services, although we do have one here for prison healthcare. So in relation to the indicator 1, it talks about complaints received and numbers escalated to stage 2. So as a result of the new complaints handling procedure, we're very much of the mind that we have to try and do an early resolution on complaints. So that's a resolution within 5 days. So you can see from the indicator there that we are definitely improving in relation to what we can resolve within 5 days. And then what moves on to what we call stage 2. So for stage 2 complaint, it is absolutely deemed to be more complex. It probably crosses multiple services, and we have to respond within 20 days. So in terms of the indicator there, in terms of number 1, that's what you're seeing in that in relation to stage 1 and stage 2 complaints. In relation to the second one, you will see that the number of complaints received are fairly static over the period, and this has continued to be monitored. You will see there's a slight blip there in terms of that March, April, and we've done a bit of a deep dive into that, and that's about 6 complaints, 5 of which have not been within the timescale. They are complex complaints and cover a range of services, including podiatry, community mental health, medicine for the elderly, dental, district nursing. So it's a wide variety of complaints there. So what you're seeing is we have, on that occasion, we've had 6, and we have only managed to do 1 within that time scale. In relation to number 3, we're looking at complaints responded to within this time scale in relation to stage 2, and what you're seeing there, the performance in meeting the target time to respond shows an improving position over a period of time. We are still below the NHS Tayside's target of 80, but we're definitely getting there, and it's a steady improvement. I'll hand over to my colleague Paul now to take you through some of the social work complaint resolutions.
On page 15.4, it's adult social work complaints received and in-time responses, and that's the frontline resolutions ones where our frontline workers and teams deal with the complaint. So you can see there's a kind of slight reduction in terms of the number of complaints, so the numbers of complaints are actually quite small. And there is a very slight dip in in-time responses as well. The complaints team don't really know why there's a variation. You can see in the lines and numbers. We do know that the number of complaints drops during holiday time, so particularly in June and December, and that's something that's well known within the team. And the actual numbers vary from 14 to 16 at any given time. So that's frontline resolutions. On page 16.5, this is stage 2, where it goes to stage 2, more formal complaint. Again, it's difficult to get anything statistical from this because the numbers are actually so small. If you see there, that's 1 or 2 people, and therefore just any variation in that can cause these sort of difference in performance because of the numbers are so small. Overall, on chart 6, it combines all of it, and the overall message is that there's a slight decrease in dealing with the complaints in time. So it's dropped slightly in both stages 1 and 2, and the complaints team are looking into that, why that might be.
Okay, in terms of number 7, we have the number of new complaints, and this is in relation to the prison healthcare service. The prison healthcare service, as you can see, has had a very high number of complaints coming through the system. The prison healthcare team have worked very hard to change the processes around complaints. And although the narrative here talks about early resolution, this is early resolution before stage 1. So they are actually speaking to their patients much earlier in the process. So we've been able to reduce that, the number significantly in relation to early resolution prior to stage 1, which is deemed a formal complaint, and then stage 2, which is deemed to be more complex. So we are making good progress there, and that is really helpful to the capacity that's needed in the prison to manage the prison ongoing in relation to not having so many complaints to respond to. In relation to the Freedom of Information, this is obviously Freedom of Information Scotland Act. You can see that the numbers of FOISs received varies throughout the year. There's no obvious pattern to this. The quantity received can often be related to a hot news topic where several requests are received on the same subject. So that is very common. In relation to the responding within the deadline, you can this is really quite a complex diagram to look at, because in order for us to respond to a Freedom of Information request, we need to respond as a HSCP within 10 days. But actually, we are responding to NHS Tayside, for example, who have 20 days to respond. So if we're 1 day out, our target doesn't look good. But actually, we probably, in the round, meet the target of 20 days. So I think it's really important to note that. And then the last one is the number of red datax incidences, excluding prison healthcare and hosted services on this occasion. So in relation to that, I think it's important to note that all red events are summarised and discussed weekly as part of our integrated management team. And also all red events are discussed at our 2-monthly clinical care and professional governance forum. I think to say that red events are usually around either deaths in custody, unexpected deaths in the community, falls resulting in harm, or potentially sort of a grade 4 pressure ulcer. Those are the types of themes that run through the red datax. So what we will do automatically is a local adverse event review, and the outcome of that goes to our local clinical and care governance forum. In relation to if we think there's organisational learning, then we will go to a Tayside-wide approach where we'll look at organisational adverse event review, and then the learning for that will will go through a different NHS Tayside process. So that's really where we're at now.
Okay, thank you both for that summary. If just before we open up for questions, if I could just perhaps draw everyone's attention to the third recommendation, which says that there's no particular exceptions that have been reported at this time. We did have a discussion at the pre-agenda committee, the pre-agenda session, in line with a question that I had about at the council. We would often, if there's any particular exceptions or complaints that are coming through regularly, would we see them? And obviously, at the moment, there wasn't any particular pattern in that regard, but we would we'd want to see those in future, and I think that was the agreement that we had. I also asked about participation requests, and we weren't entirely sure whether or not we'd had any, or to what extent we'd had them at the minute. Is there an update on that, just to confirm that we haven't actually had any yet? Okay, right. Okay, do we have any questions on the report? Councillor Drysdale.
I'm afraid I have quite a number of questions
That's
on the
all right.
report. I'll just ask a couple and then stop, and then maybe if you can come back to me. Let's just go through it in the order as presented, if that's easier for everyone. I understand the difference between stage 1 and stage 2 complaints in general. What is there on the prison healthcare report but isn't in the health and social work reports is a kind of summary of what the complaints are about. It's one thing to see information on the number of reports and how quickly we're responding to it, but I think it would be very helpful also to understand if there are any particular causes of complaints that we are seeing, so that we can focus our efforts in trying to address any recurring issues. So I wonder if I can get a comment on that, and I wonder also if I can get a little bit more information, please, on the resource that underpins the complaints process, whether we're adequately resourced in that regard, and actually what the process is if somebody were to complain about treatment received, for example, either in the health area or in terms of social work.
Mrs. Devine?
So I think your first question around summary of complaints, this firmly sits with the clinical and care governance reporting arrangements, and they are reported bi-monthly in terms of the types of complaints and the reasons for complaints is reported through to the clinical and care governance committee. So
Okay.
The question would be, would we double report it here, or is it dealt with there through the clinical and care governance process? So I'm open to suggestions on that. In terms of resourcing for complaints, that's resourced through corporate services. So we have our corporate services admin support that would support either an IGB complaint, of which we haven't had any actually yet, or they support through to the NHS Tayside process, where we have quite a big resource at NHS Tayside that supports the handling of complaints. And Paul, I don't know, from a PKC point of view, you're...
So there's a team, social work complaints team, which is basically two members of staff that basically do the complaints, do the interviewing, etc. that's required, and write the report.
I suppose it wouldn't be too difficult to have a very brief summary to include, just to give an overview like we would have at the council or anywhere else about the type of things that are coming up, and not to step on the toes of the other committee, but given that the corporate performance and in particular complaints handling is the responsibility of this committee, that would probably be quite useful information if we could include in the future report. Mr. Packham, and then I'll come back to Councillor Drysdale for his additional question.
Further to the question about the themes that come out, I'm sure it'd be quite simple to categorise them. So issues of communication, or issues of delay, or issues of the way in which people are being treated. We could, I'm sure, sub-theme them, because as it's been seen in the report about the prison, the comments that come from the prison population are pretty standard. Okay.
Councillor Drysdale?
Yeah, thanks for these replies. They're helpful and give me a bit better understanding. Okay, so I think really a couple of other areas that I wanted to touch on. The first one being on the freedom of information requests side of things. In diagram 8, when we're talking about requests received by PKC, can I just clarify that this is purely for social care rather than everything else we get requests for? Is a simple question there. And my final question really was on the number 10, the red Datix health, and thank you for clarifying what red events are, because that wasn't apparent to me. Again, reading the chart for the first 10 months of 2018, there appears to have been 37 of these events, which seems quite high if we're talking about very serious events. And I just wondered if I can get a little bit more clarity on why the numbers are what appear to me to be quite high.
Mr Henderson, do you want to address the first point about the freedom of information request?
I actually don't know, but I'm assuming they are, because I know the team receive about 7 FOIs a day from various sources that cover the whole council area, but I will check and get back.
That would be great if you could get back to the committee on that. And Mrs Devine, on the second point about the red Datix.
I mean, I think the first thing to say is that we have a very good reporting system in terms of reporting our Datexes, so that's quite important to say. This is maybe something that we would not expect, actually, in relation to some of this is reported because it's potentially out of our control. Because, you know, if it is a death in custody or it's a death in the community, we would still report that, even though it wasn't necessarily potentially within our health provision as such, if you know what I mean. So that we would still alert our people to a death in the community or death in custody. It wouldn't be necessarily because we were over involved or under involved. It's a reporting system that we would do. So if we have, for example, pressure ulcers in a nursing home, we would still report that as a red risk through our Datex system, so that we are alerting our senior managers of potential harm, but isn't necessarily being created by our nursing teams, but we would alert in terms of a Datex. So it is an alert system.
Okay, so can I just can you define as clearly as possible what red Datix means?
Well, red Datix is really where we're looking at potential harm to people, or a sudden death, or an unexpected death, or so it's really in relation to that. But it's not just in relation to health provision. It's the much wider arena. So if we have community nurses going into a residential home and they see something, they will still Datex that. They have a responsibility to Datex it.
I think Mr Packham wanted to pick up on that point.
I'd just like to give you a sort of general response to a question which is really well framed. Datex is a system that should flag up all issues of risk and concern. And one of the things that we're looking to see happen is that we have more and more reporting of these issues. So red is at the extreme, incidents that have actual or potential harm. But earlier in the process, there are lesser events. And we are encouraging people to report them more and more and more. And that allows us then to see themes emerging and to work proactively to address any systematic issues that might need to be addressed in order to improve the safety of our systems of work.
Thank you. Any further questions on the report? Sorry, Mr.
Sorry, I'm Barry Hudson.
Mr. Hudson.
substituting for Tony Gaskin, the Chief Internal Auditor. It was just in relation to your questions. I just wondered whether the adverse event management policy, which gives the definitions, might actually, if you circulated that to the members, might help your understanding.
Thanks, that would be helpful.
Yeah.
Thank you.
Okay.
Okay, thank you. Councillor Stewart?
Thank you, Chair. Just going back to sections 1 and 2, I'm not entirely sure that I'm as clear as Councillor Drysdale was about the difference between stage 1 and stage 2 complaints. So in the first graph, we have a red line which is stage 1 complaints escalated to stage 2, and in the second graph, using the same time points, we've got a blue line which says the number of stage 2 complaints received. Is it possible for a complaint to be received as stage 2 rather than escalated from stage 1 to stage 2? Because otherwise I would have expected it is. Right, okay, so that's why there's a difference between the red line in graph 1 and the blue line in graph 2.
Because if it's deemed to be complex, it'll go to straight.
Yeah, okay.
If it's deemed to be complex, it'll go straight to stage
Okay.
2.
That helps my understanding. The exclusion of prisoner healthcare and inpatient mental health from graphs 1 to 3. I was wondering why the hosted services, those hosted services in particular, were excluded, but also whether other IJBs exclude any, whether you know if any of the other IJBs exclude any of the hosted services complaints from their audit and performance reporting, because otherwise how would we know if high numbers of complaints were being received in one of the other IJB hosted services?
So just to say, inpatient mental health was probably being excluded from my performance reporting because I don't manage inpatient mental health. So that's the first thing to say, but it absolutely should be seen in the next iteration of the document as something separate, I would suggest. Prison healthcare is there actually in its own right, but we probably just need to do a bit more detail on that because the prison healthcare complaints are so much bigger, it kind of skews the reporting of it. So I think what we will do for the next one is it will be done in a separate way, but in a separate graph. So just a matter of making sure that happens.
And whether the other IJBs, whether complaints for the hosted services but hosted by the other IJBs, do we know if they're reported at their audit and performance, or otherwise how would we know that services which are effectively being delivered for residents of Perth and Kinross would, you know, those complaint numbers are being tracked and scrutinised appropriately?
Mrs. Smith?
I think when we come on to the further paper in the report around transforming governance, I think we recognise that developing our understanding of reporting on our hosted services, both how we report into other IGBs and vice versa, something that we need to focus on. I think complaints needs to sit as part of that, and we do absolutely need to understand and make sure there's an assurance mechanism such as this that is reviewing complaints, but maybe a step further in that if there are themes that relate particularly to residents of Perth and Kinross, that we are specifically made aware of that. So I think that's something we do need to take forward as part of our wider governance actions.
And I think that might be a wider point, not just within the NHST side and the IGBs with whom we obviously have a relationship through the services, but actually benchmarking ourselves, not just on corporate performance, but as we would expect to do in other areas, against other IGBs across Scotland. And if there are particular areas in relation to complaints in Perth and Kinross relative to other areas, then that might be something, or vice versa, that we could pick up on and try and find out why that is. Councillor Stewart, you had further questions?
Yeah, I was just wondering as well, we've got obviously the distinction between the health complaints and the social care complaints. I was wondering, given that we are an integration joint board and we're talking about the integration of health and social care, whether there are any hybrid complaints and how those are handled?
So I think I said at the outset, and it came to the IJB board last year, I think it was the IJB process for handling complaints, but there's still an agreement nationally that the health boards and the councils would still maintain their own processes. But so there is an IJB complaints procedure. It hasn't been particularly used because it has to come in specifically as an IJB complaint. So it hasn't really been particularly used, but it's just the national process at the minute.
Mrs. Smith?
I suppose I just wanted to recognise that whilst there may be IJB complaints, there may also be complaints in relation to services that are beginning to come together, and there may be a question around what route then. I think when I think of some of the services where we're reaching that point, presumably part of the arrangements will need to be which way are complaints going to be handled. And I think OT integration will be our first test of that.
Okay, thank you. Another question, Councillor Stewart?
Yeah, sorry. Okay, so just reflecting on another of the points that Councillor Drysdale made, knowing what the categorisation of the different types of complaints are so that we can identify whether they are themed by either nature of complaint or by area where the complaint has arisen would be useful, although I recognise that when we're dealing with such small numbers, any trending in that sense might be difficult, although over time cumulative trends might become apparent and they would provide a guide to areas for future improvement. I think what's also important to note in terms of what we're doing here is measuring numbers of complaints received, numbers of complaints responded to within certain timescales. I would like to know how many satisfactory outcomes there were in terms of whether the complainers have felt that the response of the Health and Social Care Partnership was satisfactory or not. But there is a positive in there, which is a very positive message in there, which is, and I think there's a useful lesson to be learnt from it, in terms of the number of prison healthcare complaints received. Just in the narrative, it does say that the service has started to receive compliments also for the care and treatment provided by prison healthcare staff. I think that's worth focusing on. From my experience in the private sector until last year, I would say that while we can look at complaints and trend those and focus in on areas where we need to seek improvement, what's also important in terms of continual improvement is finding out where we are doing things well and then sharing that practice as widely as possible. So I just wanted to make that point.
Thank you. Do you have any further questions or comments on the report? No? Well, thank you everyone for those questions and also for the feedback on the format of that report. We'll take that back and review that for the next time that this report comes to the committee. Just to quickly run through the recommendations, we're asked to note the corporate performance report, agree that the partnership will provide quarterly updates to this Audit and Performance Committee, and note that there are no particular exceptions being reported at this time. Are we happy to agree the report? Okay, thank you. Moving on to item 4.2. As we discussed, we now have our four programme boards, and this is the first performance update from one of those boards, which is coming from the Older People and Unscheduled Care Board. We'll be expecting to have regular updates from all programme boards, but we're going to have quarterly updates from the Older People and Unscheduled Care Board. I think the thing to note is that while this is a lot of information that we haven't had before, and this is really beneficial that the Audit and Performance Committee will get to have more scrutiny of the performance of the IGB, that this is still a work in progress, and there will be a fuller report from the Older People and Unscheduled Care Board coming to the committee in June. So I'll hand over to Mr. Packham initially. Thank you.
Thank you again, Chair. Yes, very pleased to bring this forward, and there's been a lot of work done by a significant number of people in the recent months as we've moved from our original structure within the Health and Social Care Partnership, which was very much based on locality working. We discovered that in order to be able to shape the future and make wise decisions about the way in which care will be delivered in future, that we needed to concentrate on these 4 streams of work. And today, as you've already introduced, this is a reflection of the work on older people in unscheduled care. And I'm going to pass to my colleague Paul Henderson, who's going to lead us through this report. Thank you very much.
Sorry, Rob, I'm going to do the introduction. So thank you for the opportunity to present this report. As this is the first iteration of a report like this for the Audit and Performance Committee. In relation to, I suppose, the key messages that we want to give that are threading through this report is very much the journey we've been on over the last 3 years in relation to improving our unscheduled care pathways and our delayed discharge performance. So I think it's you will see a section in this report that talks about unscheduled care, and I'm sure you'll all have had an opportunity to look at that. But Paul's going to take you through that in relation to our performance around unscheduled care. So the report very much is based on support from Scottish Government, learning from other areas, improving our performance, investing in delayed discharge support in order to get us to a better state in terms of our health and social care partnership delivery. The second part of the report also talks about emergency admissions to older people. It will explain to you how we've remained relatively stable with a sort of 1 to 2% increase in our older population year on year. It does talk a little bit about readmissions, and we'll go through that in a bit more detail in terms of further investigation we want to do about that. It acknowledges our performance in terms of end-of-life care, and we're well above the Scottish average in terms of supporting people to remain at home or in their community. And again, it talks about care at home hours, which continue to increase. It looks at our improvement trajectory around care at home. So in relation to the report itself, there are 3 specific areas: unscheduled care, older people residing in community, and then further developments we wish to make. I just want to highlight in relation to Perth and Kinross our demographic population. As you can see from the diagrams, we have an increasing older population in relation to our both over 85s in particular. So we also have a predicted strong growth in the prevalence of dementia in relation to Perth and Kinross, and much higher prevalence than most of Scotland, in fact. We've been on a very significant journey over the last few years, looking at our balance of care in terms of our dementia services by disinvesting in dementia beds and investing in our community post-diagnostic support services and care home liaison services. So that's a journey we've already been on, and we're seeing quite significant progress around that. So you will see in the diagram, which looks a little like all the lines, you'll see that we have an issue here with our working age population versus our older population. So we really need to be thinking about how we're engaging with our younger population in Perth and Kinross in terms of the workforce age moving forward. So I'm going to pass over to Paul now in relation to explaining the trajectories around our unscheduled care programme.
Thank you, Evelyn. So starting on page 24 on unscheduled care, just to start off at what was reiterating what was said at the start around delayed discharges. The charts on that page and the next page show basically consistent performance improvement in terms of our delayed discharge. Figure 1 shows the numbers of people delayed daily, and you can see there's been a consistent step change for the last 2 to 3 years over that time. And that obviously means a huge impact in terms of patients, in terms of the quality of life. On figure 2, it shows all hospitals, so PRI, community hospitals, Murray Royal, again showing the general reduction in terms of lost bed days. Figure 3 splits this up to show PRI, Murray Royal Hospital and the community hospitals separately. And it shows that PRI has had the most marked performance improvement in terms of beds lost to delayed discharges. In particular over this festive period, where normally we see an increase in terms of our bed days lost to delayed discharges, and also increased numbers of people delayed. Over this festive period, we've continued that trajectory of going downwards in terms of our performance, and that's been marked upon and quite consistent. So the report says that the reasonable explanation for that would be the numbers of improvement actions we've been doing for the last 2 to 3 years, which are listed there. Won't go into them all, but they show that each time we've introduced an improvement, it's made a change in reducing our numbers of people delayed and the bed days lost as well. We also have ongoing improvements. Again, I won't go into that, that are wanting to continue this trajectory so we can meet our 72-hour target of getting everyone out. Going on to page 27, unscheduled hospital care. So moving from delayed discharges into admission rates, so numbers of people admitted on unscheduled basis. Probably what to remark here that's quite distinctive is in December 2017, a significant spike in terms of admission rates, because until that time it's been fairly constant. We're putting that down to the respiratory and flu cases that happened at that time. Particularly that was felt particularly in December and January, around that time when there was this very significant spike. And that's also illustrated in the numbers of bed days during that time, the end of December 2017, beginning of 2018. We see a spike in terms of the number of bed days taken up with unscheduled admissions. There was actually a 33% increase during that time in the over 75 population going to hospital. Readmissions on page 28. Again, there's a spike. Generally, there was been a downward trend, but it's gone up, and I have to say we are a bit concerned about the spike there. You can see in February between April 2018 last year, when there was a significant jump in terms of readmission, so where someone's been readmitted after leaving hospital. To be honest, we don't really understand why that would be, and we're going to do a deep dive to find out, to look at the actual cases and why these patients ended up being admitted. Is it something that we could have done better? What do we need to do to improve that? So we're definitely going to do a deep dive on that one. Readmissions are generally, if they're going up, is a bad sign. We don't want that to happen. We want to manage, but they are going down since that time. There are ongoing improvements in terms of our admission, what we're doing around that, at the top of page 29, particularly around, and this touches on our older people strategy that we're planning, looking at focusing on early intervention prevention, looking at enhancing our community support, and looking at technology-enabled care, and looking at patient pathways across NHS Tayside. That's work that's ongoing, working together across Tayside to improve that. Page 29, going on to care at home. The number of clients in care home has actually been more or less static, if slightly declining. And probably the area to highlight here is that while that's been the case, on the next page, page 30, there's been basically for many years now, a continual increase in the number of hours of care at home provided. So it is going up slightly, while the numbers of clients are over this last year been remaining the same. And that's something that we've been looking at through a care at home improvement review, and also care at home improvement planning, to make sure that this isn't around any service issues, but around issues around client need. We would expect, as we personalise services more, and these particular increases around the more personalised self-directed support options, that's where these increases are happening. We would expect that that often means the services and the hours delivered are more personalised and therefore possibly higher as well. So that's something we've been looking at in this care at home review and improvement programme to explore that a bit further. Page 30, reablement. It shows the first chart, figure 9, shows the number of reablement clients. And you can see the variation in that, particularly from the end of October and a spike in February 2018, and then it goes down again. This was around the time when we introduced the heart service, when we joined care at home and reablement and began to deliver a new type of service. So that became fully operational in February 2018, so the numbers of reablement clients increased. We then had a significant amount of staff that left the service, and we were recruiting over that time, so there was a drop. That's what we think explains the sort of that variation in terms of numbers. Figure 10 shows a general decline in people that don't need care at home support after reablement. So this is where someone would be fully reabled and therefore wouldn't need social care support anymore. We're exploring why it's gone down so much. We think it may be with the just basically a numbers thing about joining up care at home and reablement, and what the stats look out when we draw them out, and whether that includes care at home clients who wouldn't necessarily be reabled. We're also wondering if it's some of the more complex needs, people that require more complex needs that would anyway have gone out without, that wouldn't be reabled, if they have some dementia, or more severe dementia. So that's something we're looking at now, because obviously the trend going down is not something we want to see happen. We want to try and reverse that or stop it. In the further areas we want to look at in terms of performance at the end, one of the things we want to look at is not just those that have reablement and then don't need any sort of social care service, but also those that have reablement and then maybe have a decline or less social care service, because we're not actually capturing that as a performance figure, and we think we're missing out on something there. The next section is around technology-enabled care. And just a section about the actions we're doing around that. And in terms of falls prevention, that's figure number 11 on page 32. In terms of our prevention, we're in terms of the Scottish average, we're actually we're about middle in terms of the rest of Scotland. There's a slight improvement in that. You notice that there's, I just wanted to point out on that chart, figure number 11, there's a spike again around December 2017, just in the numbers of falls that weren't prevented. And that's an area, again, we're going to look at a deep dive to figure out why that is, because it kind of sticks out there in that chart. Moving on to page 33, and supporting people at the end of life. There has been an increase in that, and which is good. I would say that supporting people as much as possible at home, it's obviously there's a bit of personal choice in there as well, because some people may not want to go to home, they may wish to go to a hospice or something, but that's a positive indicator there in terms of our performance. And in terms of the Scottish average, figure 14, we're actually doing better than the Scottish average in that area, as you can see in that chart. Page 35, residential and nursing care. There's been a slight reduction in the increased demand for residential care, and conversely, there's been a reduction in nursing home placements. I mean, the numbers aren't huge, to be honest, but it does go against the trend that has been going on for the last 2 to 3 years, where we've seen less residential places and more nursing home places, and that seemed to be in line with our aims of keeping those that we would support those with more moderate and needs in the community for as long as possible, and it would only be those with the most complex needs that would have to go to a nursing home, and therefore that's based on our assumptions. So we actually don't know yet whether that's whether this is just a bit of a blip, or whether this is something more sustained. So that's something we're looking at. And just future performance areas that we want to look at in terms of the older people strategy. I mentioned the reduction in care hours following reablement. We think that's something we're missing right now. We think because anticipatory care and preventative care is something that we want to put further resources in as part of our older people and our scheduled care, we'd like to see whether there's a way we can measure the anticipatory care plans following diagnosis of dementia. We want to look at the number of people in supported living services, so not just residential care and nursing care, but those that are supported in the community, perhaps with more complex needs, but in supported living services. The number of occupational therapy assessments, rehabilitation and reablement are key parts of our strategy. So we're going forward, we want to be able to assess that. Looking at the e-frailty tool, which is a way of measuring someone's frailty, we particularly want to support people with not just very complex frailty, but with more mild and moderate frailty. Its evidence suggests that if you can address, highlight and find people that have, identify people that have more moderate frailty, you can make much more difference in their lives in terms of rehabilitation. And numbers of people with continence issues that we can support in the community. So all areas that we can look at supporting people in the community, basically including continence issues, and everything to do with intermediate care around reablement and rehabilitative support. And also the number of people supported by telecare in the community. That's my just gone over now. As I said, it was high level, so happy to take any questions.
Thank you very much, both, and in particular Mr. Henderson for that very comprehensive overview of the report. Just as I said in relation to the last report as well, if anyone has any feedback on the format of the report in addition to their questions, that would be really helpful. So first, Mrs. Stewart. Thank you.
I wanted to say that I very much welcome this report, and also that I very much appreciate, I'm sure as colleagues do, the significant work by the teams to bring this first reiteration of the report. So I really would like that conveyed back to those that have been involved in it. I appreciate that it's going to have been a significant amount of work. I have a couple of questions in regards to some of the timeliness of some of the information that we're getting. Many of the reports are very much up to date and are reporting on December and January figures. But I did note in regard to delayed discharge, unscheduled care and readmission, we're actually looking at figures relating to October. And I wondered whether going forward we would expect that to be more current and more relevant in line with the other reports that are later. And one area of particular concern was the residential nursing care report. It seems to be reporting to July 18, which seems quite a long way from February 2019. So it was just really whether that in terms of the future performance we're looking at, I believe you're looking at it being more sophisticated. I'm just perhaps emphasising the timeliness of the reports in conjunction with that. Thank you.
Mr. Henderson?
So the report took, various bits of the report took some time in the making, so some of the timescales are a bit out because of that, so that's something we want to address, because it was the first report. We had to kind of try out things a few times around that. In terms of the numbers and the figures around residential and nursing care, at the minute there's a resource issue in terms of our looking at data from our social work information systems, and there's a recruitment going underway to achieve that, and that's been part of that blockage. We just haven't been able to get the data in time.
I think it's also important to say that some of these are MSG indicators and they're created from ISD. Sometimes the information is lagging behind and then it has to be verified, so it's very difficult to put it all into a report if it's not verified, because we can get it for management, you know, a management look, but reporting it to a formal committee is.
Thank you. It's very helpful to understand the restrictions and the difficulties behind that in terms of resource. I think we note that. Also, in regarding the future performance reporting areas, I wondered whether there is any timelines planned. It's quite an extensive list that you have there, and I just wondered whether you plan to have any timelines around that. Thank you.
Mr. Henderson?
Yes, we would. I think we will be taking these to the Older People and Unscheduled Care Board for further discussion around that, and particularly some are aspirational. We probably might need to build systems to actually gather them as well.
Thank you very much.
Councillor Drysdale.
Thank you, Chair. Again, I'd just like to echo Mrs. Burst-Stewart's comments. Thank you for the work that's gone into delivering this report. And it's doing its job, because what it's doing is prompting more questions to which there may or may not be answers, and I appreciate that. But that's the journey that we're on, and you know, we need to get better at understanding what the messages are from all this data. Again, I'm afraid I have more than one question. A very easy starter for 10, which is, what's Code 9?
So Code 9, that's the name of something on the information system, Edison. So it's one of the codes that basically defines a set of patients and the reason that they're delayed. So it consists of two things. It consists of people waiting for what's called incapacity issues. So could be waiting for a welfare guardianship to be enacted. So that's one element of it. But the other element is complex care. So perhaps where there's very complex arrangements to provide the care, it could be that there's housing, specialist housing required, specialist equipment. It could be the patient has very specialist needs. So that code covers both these areas.
Thank you. So essentially difficult situations that need to be resolved, yeah. Okay. A much more fundamental question now, which is the data presented under unscheduled hospital care at 3.3 paints a picture of reducing bed days and improvements in terms of the delayed discharge key performance indicator, which of course is the one that gets all the headlines. However, what concerns me in particular is the pattern of readmissions and the rate of readmissions within 28 days following discharge of elderly patients. And obviously, it's brought out in here that this needs to be further investigated, and damn right it does, because you know, that is a real concern. It prompts the question whether people are being are going out of hospital before they're ready to, whether indeed the judgment calls being made are correct. Now, as I say, it's a question. It's not a statement of fact, but I am concerned that readmission rates are uncomfortably high, and I wonder if I can get a comment on that.
Mrs. Devine?
So I think there's two things to say in relation to readmission. The categories of readmission are, if you're readmitted within 7 days, it's deemed as a failed discharge. If you're readmitted within 28 days, it's deemed to be something that the community could maybe have dealt with differently. But the other thing to say is we've done deep dives into readmissions before, because obviously it does worry us. And it's very difficult unless you're actually following the person themselves, because they could be admitted for a completely different health reason. So they may be admitted once for one reason and then admitted again for another reason. So that's quite difficult within the ISD categories to work that out, actually. However, I think we are given a commitment that we believe ourselves that we need to be doing more about this. And I think at the minute we have our integrated care teams working in all of the localities with an absolute eye on those people who are frail in their locality. You'll see there is a bit of a blue dot which is further down. And you can see if we were to continue to progress, we would be looking at maybe a 50% less readmission than we are at the minute. So we need to see how that pans out. But we're absolutely, we've got about, each locality has at least two integrated care teams absolutely focusing on frail older people, and with the multidisciplinary team bringing people they're worried about. So it is our intention to do more of that. However, there is still an issue about preventable admissions, and we know we need to tackle that. So.
Thank you. Councillor Drysdale.
Moving on. Under 4.1.4, under falls prevention, some interesting data here, and something that is very useful to see is a comparator between Perth and Kinross and other local authority and health board areas. It seems to me that there's a pattern that again, if somebody falls and is admitted to hospital, there are two subsets of falls. One is falls outside, which may be weather related and road and pavement condition related, which is an issue for the local authority, and the other is falls within the home or the home environment, which may be related either to frailty or whether homes have been adapted and so on for disabilities. I wonder if we can in future. I wonder if it's possible to split the data into indoor and outdoor falls, to see whether that gives us any learnings that we can build on. And I also make an observation that, sorry, just bear with me. But no, I'll leave it at that for falls prevention. I've got another couple of questions in relation to other matters, but I wonder if I can get some comments on the falls prevention side first.
Mrs. Devine?
I think the easy answer is I don't know. I think this will be an ISD information that we've been given, whether I would suspect it would be very difficult to unless we were to put in a local indicator somehow, and I'm not quite sure how we would do that. But it's certainly something that we could have a conversation with other, with the NHS, performance team about. Ideally would be a good thing to know, absolutely.
I do wonder if the ambulance service, for example, would be able to help in that regard, because they do seem to have comprehensive data.
Yeah.
Can I just pick up on that? In relation to this and a number of other things we've talked about, the ISD information that's coming, and the inability then to split that and to look at different categories, which would give us more information, and perhaps for this committee we might feel more meaningful information. Obviously we have to make sure we're doing the MSG indicators, but are there other sources of information that we can use in order to design indicators that we would find more meaningful?
The short answer is I'm not sure. I think we would have to build something in terms of falls. Yes, I think we could. We definitely have a good partnership with the Scottish Ambulance, so there's definitely something there that we could look at. We have a falls pathway, which would, we could maybe be putting some indicators alongside that. But
I think I wasn't just meaning in relation to falls. We've talked about readmissions as well, where we're using that information, and actually if that can give us a better picture about, if people are being readmitted, if it's for something different rather than the thing for which they were in before, and that type of thing as well. Mr. Henderson?
Yeah, so there's currently work on what's going to be the new information system for social work, and I think there's opportunities there to build in elements to that that we might want to gather. We're already looking at that in relation to the Carers Act and gathering in performance information about in relation to carers, so that there's no reason why we can't look at it in relation to some of these areas.
Thank you. Apologies for hijacking your questioning. Councillor Drysdale, back to you. Oh, in relation to this?
Yeah.
Councillor Stewart.
I was just to say that I know, I think I understand the point that Councillor Drysdale's making. If you look at that sort of spike, that red outlying figure in the graph in section, in the figure in section 414 of the report, which would be about December 17 or January 18, if I'm lining it up. I think that was a worse winter, and what I think we should reflect on is the fact that in the winter planning arrangements this year, which I think certainly the NHS Tayside board members around the table were all reassured were much more robust than previously. One of the actions within those winter planning arrangements was for if there were live reports of particularly high numbers of sprains or falls or trips within a particular postcode area, then service managers were able to contact Tayside contracts directly to get extra action in those particular areas. So while I appreciate the point that Councillor Drysdale's making about the data to understand what's happening, regardless of what was happening, the arrangements were put in place within the winter plan to deal with that.
So my Freudian slip on Friday about winter maintenance rather than winter planning was not so far off. Mr. Packham, you wanted to pick up on that.
Thanks. I'm just drawing on my experience as a rehabilitation professional just to speak to Councillor Drysdale's question about the intrinsic reasons for falling inside and outside. Perhaps we could think about environmental factors, things that people trip over, fall over, etc. And then there's issues around how well somebody is, and there's multiple reasons why people might fall. Some of those are under our control and some of them are not. So therefore, in terms of breaking that down, it might be interesting to explore how that's best described in order to understand what is preventable and that which is less preventable.
I think also On a different question. Okay, Councillor Drysdale.
Yeah, so sorry, just following on from that. Yeah, I mean, this is what it's all about. You know, this is what we're here for, to try and prevent falls where possible. And you know, it's, as I say, it's if and it's fairly evident that the spike that Councillor Stewart referred to in last winter is more than likely due to the weather conditions, and therefore the road conditions and the pavement conditions, and that is something that is within the gift of the local authority to do something about. You know, without wishing to put this to too much of a base level, you know, a bucket of salt on a pavement can make all the difference in the world, and may reduce to some extent, at least, the pressure on health resources if adequate funding is applied to roads and pavements. I make that observation just as a general one, but it also applies, you know, within the home as well. And if, as Mr. Packham is suggesting, it may be possible to identify common causes of falls, especially within the elderly group, then, you know, if social services can be alert to these and can seek to prevent them before they happen, then that's us doing our job, I guess. Moving on to this, you'll be glad to know the second last question that I was going to ask, which was under 4.1.5, supporting people at the end of life. I'm just making an observation here, looking at figure 14 on page 34, and the the relative place of Perth and Kinross within the national picture. It seems to me that, what we're looking at here is the percentage of last 6 months of life spent at home or in a community setting for Scottish partnerships, and it seems to me that the percentages are higher in rural oblique remote locations more so than they are in our cities. This is obviously not a Perth and Kinross issue per se, it's a national issue, and I just wonder if MD can give any suggestion as to why that might be, why it's clearly the more rural areas where people are spending more of their life at home at end of life.
Mrs. Devine?
It could well be a combination. If you look at the people at the top there's quite a few of these people with community hospitals. So people may choose to spend their last 6 months or coming up to their last 6 months in and out of a community hospital, but be maintained at home at the same time. So I think it might give confidence to a family or whatever, just having that access to that. But I, from an urban perspective, I'm not really sure. I mean, we've obviously got Cornhill within Perth City, but I think we do a lot of palliative care at home in Perth City. So can't really make a correlation there, because I know that we do a significant amount in Perth City. So.
Is it related to this question? Okay, Councillor McDade.
It's more just sort of from personal experience of constituents in Highland Perthshire, where obviously it's a long distance to travel to hospital. Generally, there is community hospital support there, where I think this is picking up on basically what Eric's trying to get at, is that in these sorts of, the ones that are at the top of the table, to get to the sort of care that there might be, it's a really long distance for the relatives, themselves as well. So there's probably more being done by people, in my experience anyway, in the rural areas, to try and stay at home, if at all possible, through a network of, and I know of people who are being looked at the moment by neighbours because they want to be at home where they've got that support network, whereas if they were in Dundee or Perth, people just couldn't get there. So I think that kind of was what Councillor Isaac was getting at.
Mr. Packham?
So there's another interesting statistic to consider in this, and that is that the closer you are to a hospital, the more likely you are to be admitted. And there's something around about the resilience of rural practice and the way that solutions are found for people where those acute hospital facilities are less available.
Thank you. And the promised last question, Councillor Drysdale.
Sorry, but yeah.
No, absolutely. The more questions, the better.
So, unsurprisingly, given you know what has been spoken about in previous meetings of this committee and of the IJB, I wanted to focus on 4.2 residential and nursing care. And so the question of whether this is a blip or whether this is evidence of a misunderstanding previously of trends. So what we're seeing here in 2018, insofar as we have the data here, is an increasing trend in demand for residential care, which is completely contrary to what we previously understood to be the case in 2017. Now, it's so important that we understand whether this is a blip or whether it is in reality a trend where there is still demand for residential care. And I say that with respect to ensuring that there is sufficient capacity within the care home network, the public sector care home network going forward to accommodate any demand. So, you know, it would be very good ASAP to see the trends through the last 6 months as well as the first 6 months of the year.
Mr. Henderson.
Sorry, once we have the trends of the year, and if that indeed continues with that increase in residential and decrease in nursing, it is confounding what we thought previously. So I think we need to see these trends and see if this is literally just a blip or not. It's too short a time scale to see right now.
And I suppose there's also the question of, we obviously have the pressures of an ageing population, but whether the things that we are doing are offsetting that, but the net effect is still an increase. Whereas if we weren't doing more support within the community, then actually the increase would be even greater, and whether we can separate that out. Pete.
Sorry, just in relation to that point, I wonder, would it be helpful also to see the length of stay in residential nursing care, not only the numbers, but perhaps the correlation between any variation and the length of stay, whether the length is shorter than it ever has been in the past?
Yes, certainly, and that's an area we want to look at in terms of our ongoing strategy. We want to have a shorter length of stay. I'll look at that.
And you had your own question as well.
Right. It's helpful to see the information, obviously the numbers and the trends. I wonder if you could describe to me, and if I should know this, I apologise, but for me it would be really quite helpful to see this in relation to the outcomes for individuals. I mean, the last item on the agenda was about complaints and there was note of compliments, but I wonder, these services and the number of people that are using, what's the impact on the individual and what's their experience of using the services, and if you could describe to me when we see that, if we see it, for me it would really be helpful to know what people's experience of these services are, and whether the services are meeting the outcomes that had been anticipated for the individuals that are using them.
Mr. Henderson?
I think that's a really good point. That's certainly something we can look at in terms of going forward with this. We certainly do, in terms of outcomes, we do measure them from our social work reviews. So that's part of our reviews. We measure the outcome, but also with teams who do gather that type of qualitative information, and it's how we can do that to supply that.
Okay, thank you. Councillor Stewart.
Thank you, Chair. So I think just a couple of points. If I went back to section 3.1 in the report relating to the delayed discharges and figure 3 there, the bed days lost to delay monthly by facility type, it's more just an observation. I mean, somebody may want to come in on this, but it's more just an observation than a question. But that blue trend line there, which relates to the top trend line, which relates to monthly bed days lost to delay at PRI, if I'm picking up the right data points which correspond to that trend line, then actually it's not only an improving trend, it's a much more accurately described trend, because the data points are getting much closer to the line as we move towards the right of the graph. So I think we've actually got quite a lot of confidence that that is a genuinely sustained trend. And while obviously I think it's higher than we would want it to be, it is certainly a marked improvement and definitely heading in the right direction. So that doesn't require a reply. My other question, I think this is one for Mr. Henderson, 4.1.2 on reablement. The last in figure 9, the 65 plus 65-year-old plus reablement clients, and the increase that we're seeing October, November, December towards the right-hand side of the graph. I think I picked you up right in saying that there were people that within the heart service, the home assessment and recovery team, that there had been a movement of staff out of the heart team. Is that correct?
From the beginning of last year up until round about autumn time, because there was been a large organisational development, so some staff left the service who'd been part of the service, and we had to do this enormous recruitment drive, and we recruited another 18 staff to fill these posts. Basically, and we recruited these towards the end of last year, so it meant that the service didn't have enough capacity in terms of its reablement potential and to reable the numbers of people. But now we've caught up with that, and that's where the numbers. I'm assuming that that's why the numbers have increased, because we've got more staff to do it.
Thank you, Mr. Packham. You wanted to pick up on that?
Thank you. It was going back. It's going back to Councillor Stewart's point. At the point at which the partnership started in April 2016, we had been through a phase of Perth Royal Infirmary having the worst delayed discharge performance in Scotland. So it was just to reiterate the amount of work that has been done in order to sustainably reverse that trend, and the lessons that have been learned from that are now being applied to mental health and will be applied to other elements of our service out in communities equally.
Thank you for that point. Councillor Stewart.
Yeah, sorry, thanks. Just to come back in on Mr. Henderson, right, that's really reassuring. I think I was reading the graph upside down, so an increasing line towards the right-hand side in terms of reablement is good, because it's not reflecting the fact that there are more people needing reabled. It's the fact that we are getting through more of the client, the people who need it. Right, that's very reassuring. And the other thing I think I would just like to say as a comment, yourself and Ms. McLean, the team leader from Heart, were good enough to give Councillor Purvis and I a presentation on the work of the Heart team last, maybe around the middle of last year, I think, July, August time, and the efforts of the Heart team and the projects and streams of work within the Heart team are really encouraging, and I think everybody in the Heart team in particular is to be applauded for making these efforts to reduce length of stay in hospital, to therefore reduce delayed discharge and so on. So just to pass that back.
Thank you. Do we have any further questions or comments on the report? Councillor McDade.
It's just a comment actually about some of the answers that are being given in terms of, for any member of the public who should be bored enough to want to watch an Audit and Performance Committee, we're using an awful lot of acronyms here, and actually it doesn't make it very accessible for the public to understand what we're talking about. I think it's something we should be conscious of, because, and you know, we have now been in post for 18 months or whatever and getting used to all the acronyms, and perhaps aren't asking the questions to make prompt people to get the answers. So I think that's just something to be aware of.
No, I think that's a perfectly valid point, Councillor McDade, and that doesn't just apply to the verbal responses that we get, but also to the papers. And we've spoken about that in terms of the acronyms in the past, making sure that the first time it's always put out in full, but actually some of the points that Councillor Drysdale has raised in terms of the jargon that needs to be made clear to members as well as the public what it means. Okay, is that everyone? Right, well, just to reiterate the comments that have been made by other members of the committee, thanking yourselves and your teams for bringing this report forward. I think it's very helpful, and I look forward to receiving further reports on this in the future. Just to quickly go through the recommendations, we're asked to note the Older People in Unscheduled Care Board Performance Report, which you've had before you today, and to agree that the Older People in Unscheduled Care Board will provide quarterly updates on progress and performance of that board's activity to the Audit and Performance Committee. Can we agree to the report? Okay, thank you. Moving on now to the governance section of today's agenda, and the first item is 5.1 on strategic risk management. As you'll know, we have previously agreed the new risk management framework, and as I indicated at the start of this committee meeting, agreed that the risk management profile would be brought to each meeting of the Audit and Performance Committee, and that's what we have before us today. So I'll ask initially Mrs. Smith to introduce this report.
Thank you, Chair. Yes, at the last meeting, the Audit and Performance Committee members endorsed the high-level risk profile. Within that risk profile, there were 3 key areas that were highlighted as high risk: finance and around the availability of resources to support strategic objectives, workforce, availability of workforce to support our strategic objectives, and leadership. What we've been doing since the last Audit and Performance Committee as Executive Management team is focusing at every meeting on the development of action plans to do everything we can to bring the level of risk across these 3 areas in particular down. What lies behind the risk profile has been a significant amount of work. At this stage, however, all of that work has not enabled us to reduce the level of risk around the 3 reds, as we would describe them, to amber at this stage. So whilst disappointing, I don't think it in any way necessarily reflects how close we are, and Rob may want to come in and talk about some of the specific risks in terms of moving this to a more acceptable level. As well as investigating, developing the action plans around the red risks, a significant amount of time now looking at amber risks, because the last thing we want is for amber risks to be escalated to become red. So that now will become part of the regular activity of the executive management team to be very much focused on the amber risks. Rob and Fiona as well, who has supported us supported the ongoing review of risk across the partnership. Is there anything else you want to raise?
Mr. Packham first, and then Mrs. Easton.
Thank you, Jane, and thank you, Chair. Yes, this has been a piece of work we've been concentrating on with some rigour in recent weeks and months. If I work, first of all, on talking about workforce, there are obviously increasing demands from an ageing and a more complex population. And with the particular challenges that we have in Perth and Kinross of being both an urban and a quite remote and rural community, some of our problems are magnified in the more rural areas. So we've been thinking very carefully about how we go about strategically managing that into the future. And some of that is manifest in some of the performance figures we've just looked at around older people and unscheduled care. Some of the delays are built into the system simply because of the issue of supply, of the right numbers of the right types of staff to deliver care in the right places and at the right time. So workforce planning is something that will have to become increasingly integrated, and it's not just about health and care, but it's also about the independent provider sector for care at home, for residential care, and looking also at the role of the independent contractors, particularly GPs, around the new primary care strategy, and what we will be expecting to change in the coming years as there's an increasing expectation of the role of primary care, GPs being the leaders of a specialist generalist team in communities, and obviously building new and vibrant communities around community treatment hubs that will in itself act as a catalyst for staff to be attracted into that role. Clearly within weeks we face the issues of Brexit and the decision that will be made nationally about that. That is something that we have been considering carefully. I have written to the two chief executives as the chief officer of the IJB to gain assurance from them about the preparedness of the two partner organisations. Now, there is activity in Perth and Kinross Council that we have been part of, and similarly there is activity in NHS Tayside looking at the numbers of staff who may be European nationals who may or may not stay within the UK. We've been considering the issues of procurement and supplies, particularly around about drugs and supplies for delivering care and treatment services. And then the final issue that we've been considering is that if there were a number of people coming back to this area from Europe in the future, we would need to think about the impact that might have upon health and care services here in Perth and Kinross. There are some projections about the number of people who will come back to the UK, potentially from elsewhere, but we don't know exactly what that might mean for the community here in P&K. So I'm awaiting a formal response from the two parent bodies in order that we can actually note for audit purposes the level of preparedness that there is within NHS Tayside and Perth and Kinross Council. However, I can assure the committee today that in both of those organisations we have been both involved and have communicated with our colleagues in order to minimise the impact or the potential negative impact of anything that might come from Brexit. There are probably a few other things I would like to mention around about leadership, if that's okay, just as I have the opportunity to speak. This development of an integrated health and social care partnership has probably been one of the most complicated changes in the health and care services in the UK since 1948, when the health services were set out as in the way they have been. People would say that it was perhaps a pity that social care was not included at the time of the inception of the health service in the UK, because there is such a close relationship between both health and care, and the people who we serve are not particularly troubled by which service it comes from. But unfortunately, the way that our services have been born of different legislation and different philosophies of living, we have had to try and work in this last 3 years to minimise the impact of that change. So in leading that, we have been dealing with issues of culture. We've been dealing with issues of requiring to deal with the present. That's, in other words, running services day to day, thinking about the issues that we inherited as a partnership that were already live within the two partner organisations at the point the partnership was brought together, and also perhaps now the greater focus that's emerging on integrating services at pace. So I would like to reflect on the fact that we are a small team who are trying to fulfil at least 3 purposes. And in recent months, we've had something in particular to encounter, which is that we set ourselves up very deliberately at the beginning of the partnership, wanting to protect the very best of professional standards and delivering services safely and effective for the population, understanding that in time and with a cultural amalgamation, we would see a gradual blurring of the boundaries between health and care services and minimising the duplication, the overlap, and minimising any gaps in service that were appearing at the time. So my colleagues have had to work in localities. They've had to think about the geography. They've had to think about how they will organise and reform teams around the north, the south of Perth and Kinross, and also the city, those 3 localities. And we built an infrastructure to make that happen. At the same time, we've recognised, as we discussed earlier, the need to be able to set the compass right. In other words, set the direction of the future of clinical and care services. And the programmes of care have been designed in order to maximise the opportunities for modernisation and improvement of quality of care for the people that we serve. So in that, the small teams that we have in leadership have been trying to transcend two functions and to overcome where they have roles both as professional leads, locality leads, leads in an organisation, and then leads in an increasingly integrated function. So we have recognised that the structure that we set off with is probably not the structure for leadership that we require for the future. And we need a far greater emphasis on integrated operational leadership. And we need a far greater emphasis on strategic planning than we've been able to give to the service to date. So in discussions with my position in Perth and Kinross coming towards a close at the end of April, and the new chief officer coming in at the beginning of April, one of the things we've been trying to navigate is how we allow the new chief officer to set his stall out for how he would like to see the services evolve in the coming period, however, building on the lessons that we've learned. So in our leadership section on page 41, you will see a fairly honest reflection about some of the things that we now need to do in order to take the partnership to the next stage of sophistication. This is a complicated evolutionary journey, and I have to say the thing that pleases me most is that considering that complexity, the team has remained strong and bound in its common purpose to see things improve and to see things increasingly integrated.
Thank you, Mr. Packham. Mrs. Easton.
Chair, thank you. I was just going to reiterate the need for the strong process that we need to apply to the risk management profile, and that although some of these reds are still red, there is action plans behind it, as Mrs. Smith said, with far out dates. So we've come too early, possibly, to the Audit and Performance Committee with the report to actually update you on where we are with each of the risks that have been identified. Most of them will have moved by the next time we meet.
Thank you. Councillor Stewart.
Yep. So taking in mind what Mrs. Easton has just said, it was just to flag up that strategic risk 8 is missing a risk manager, and strategic risks 3, 4, 6, 8 and 9 are all missing due dates. There was one particular thing which, because I'm aware of it, because I'm aware of it, I don't think it's quite right, which was under strategic risk 3, which was to do with the lack of a joint working agreement and the consequences that could result from that. While there was a proposal at the Council's Strategic Policy and Resources Committee in November 2018, I don't recall that coming to the NHS board in December 2018. I think that still has to happen. So it was just a point of correction, if indeed I am correct.
Mr. Packham.
Thank you, Councillor Stewart. I can assure you that the process is ongoing, and though it be slower in the NHS, it is reaching the point now where the 3 chief officers have been written to this week by the Deputy Director of HR, Mr. Christopher Smith, to make sure that the conditions within the joint working agreement are to the satisfaction of all 3 partnerships. It then goes to the Workforce Advisory Group in NHS Tayside and forward for approval.
And does that mean that we're looking at a joint working agreement that will apply for all 3 IGBs? Because the initial, and because we couldn't get agreement with Angus and Dundee, we were looking at Perth and Kinross almost doing a pilot or a trial scheme. Is that correct?
That is correct. And in fact, the offer to Angus and Dundee is for us to work with it for a year to learn lessons and share them with our colleagues in Angus and Dundee. They have taken a different stance in terms of their risk appetite, and that's the reason why they've chosen to proceed without it. However, the advice we've been given is that it would be wise to have this agreement in place, and therefore we, along with the four chief executives actually in Tayside, all agreed that this would be something the organisations would sign up to, with the learning from Perth and Kinross applied to Angus and Dundee.
Okay, thank you. Mrs Easton?
Can I just answer to Councillor Stewart? The purpose of bringing the risk profile today was to update you on the risks, the red risks. The amber risks and the green risks have been worked on separately. So apologies if the actual profile that you've been given has not got all the details in it. It does now.
Thanks.
Councillor Drysdale.
One or two questions again. But first of all, I would just like to publicly thank Mr Packham for his leadership in bringing this integration joint board to life and facing the huge challenges that are presented by the requirement to deliver fully integrated adult social care and health services to the people of Perth and Kinross. As he points out, 70 years of separate organisations delivering these services can't be brought together overnight or anything like overnight, and the fact that we are making progress now and having been on the IJB myself for the last 21 months, clearly seeing the progress now being made. So thanks to Rob for his leadership, and also to his colleagues for their efforts in that regard. I think it's possibly the first time that Rob has delivered a summary report without mentioning finance, but I would want to flag up that whilst progress has absolutely been made in this round of budget discussions, and we understand the situation. I understand the situation much better than I did 12 months ago. We're not there yet, and I just want to put on record that I would sincerely hope that and believe that Mr Patterson, the successor in office as Chief Officer and Director of Health and Social Care Services, will take this forward so that we do genuinely, by this time next year, have a properly joined up approach where the requisitions made perhaps come before the requisition offered rather than the other way around, and so that we can try and make the sums add up. They are very complicated sums. I just make that observation. You also didn't mention the political dimension, and I just again wanted to place on record my appreciation that my colleagues now on the IJB from the political side, we look like we're in this for the journey, and I'm glad that we now have a bit of stability so that we can try and make some progress in the period ahead. And after my ramble, I just wanted to really just ask one question of Mr Packham. He did make reference to the dreaded subject of Brexit, and I did want to kind of put you on the spot, Rob, and ask you for your judgment as to what risks do we face in the event of a hard Brexit?
Can I just pick up first on, I think you're absolutely right in terms of the requisition, that it would be better to have made the formal requisition in future in advance of the the offer in the officer recommendation from Perth and Kinross Council. But just to clarify for the record that both Perth and Kinross Council and NHS Tayside were given an informal indication of what the budget review group's position was, having received approval from the majority of the voting members of the IJB, that they were happy to make that offer, and that the requisition was the same as that. But you're absolutely right, but just to clarify that. Mr Packham.
Thank you, Councillor Drysdale. I don't pretend to be an expert in Brexit or the impact that that is going to have, but what I do know is that we have some extremely valued colleagues from Europe who work in our system, both in the health and care services directly, but also amongst our care services that are delivered through independent providers. I don't think any of us really know what the impact is going to be, but we have communicated with people who are European residents working with us, and we've given them the opportunity to come forward to reassure them about a future with us in the service. Clearly, there's a large element of personal choice in that. And similarly, as I look at this, it's difficult to navigate the direct impact that, say, the supply chain will have on our services. We'd be very dependent upon the availability of medicines, dressings, many of the things that our clientele rely on daily. So I, as the Chief Officer of the Health and Social Care Partnership, have the privilege of leading the planning and commissioning process. The delivery and supply of services is delivered in Perth and Kinross in our integration scheme through the two parent bodies. Hence my communication with the chief executives to make sure that in their systems of work there has been adequate consideration of the risks that we face. And obviously the next few days will tell us how it's going to work out, but I would imagine that the impact of this decision will be with us for quite some time.
Thank you. Any further questions or comments on this report? No? Okay. Just go through the recommendations. We're asked to... Wrong paper, sorry. We're asked to note the progress in managing the high-level IJB strategic risk management profile. Can we agree the report? Thank you. Moving on now to item 5.2, which is the Transforming Governance Action Plan. The Audit and Performance Committee saw the annual governance statement in June last year and approved that, and this is giving us an update on the action plan, monitoring progress in relation to that annual governance statement. And I shall ask Mrs Smith to introduce the report.
Thank you, Chair. Just to remind members that the annual governance statement and our ability to sign that off was supported by a really comprehensive self-assessment undertaken by the executive management team in line with SITFA best practice governance standards. We've done that for 2 years now, and it has allowed us to identify both our strengths and our weaknesses. And as Rob indicated earlier, as a fairly new fledgling organisation, we should not be surprised to see a number of areas where we need to strengthen our governance arrangements. The Governance Action Plan is comprehensive. It does include a number of key areas, but I am absolutely sure that a number of these areas are consistent with other IJBs, both across Tayside but also across Scotland. I don't plan to go through this line by line. We've given an update on where we are, but I'm very happy to take specific questions on the individual actions as they've been laid out and the updates.
Okay, thank you, Mrs Smith. If I could just perhaps pick up on a few of the points following the IJB meeting on Friday. If number 4, it might be useful to also note that the formal recommendation from the members of the board that a more collaborative process, an even more collaborative process, I think was the wording that we used, would be adopted in future. In terms of number 5, I think this links on to the point that we were talking about in the action plan update, the update for the previous committee meeting action points update, about bringing forward a document that would show us about the governance structures of the IGB and the different reporting mechanisms, because we have had discussions before about the role and remit of the strategic planning group. And I think it would be really helpful for members of the IGB if we could have some more clarity about that role and our involvement with that as well. So if we could add that. In terms of number 7 on the review of the use of directions, obviously we had the first use of directions at the committee meeting in February last week. We also had a discussion at the pre-agenda meeting that it might be very useful to have a summary that could be provided to all IGB members to inform us of, give us more detail about directions, what they should be used for, and so that actually when we are seeing committee papers coming forward which either have a recommendation to use a direction or not, that we're able to scrutinise and challenge the judgment call that's been made by officers in relation to that, and ensuring that we're performing our roles as board members as well. So I think that would be helpful. I think that's all my points.
Could I just come in briefly around directions? I think the meeting, the IGB meeting on Friday was our first chance to try to take into account the implications of each report and the directions arising from it. I think if we were being honest as an executive management team, we found that a challenge. You know, we need to reflect on, you know, why that was, you know, difficult for us as an executive management team. Is it around the level of support that we need from our legal colleagues around the wording? Is it that we need to sit down more closely and understand the national guidance that's been provided to us? But I think it would be wrong to sit here and say that was an easy process, and I think there's lessons to be learned as we move forward as officers, so that we can then also support our members in understanding how best to use directions to achieve the aims of the board.
Okay, thank you. Mr. Packham.
Thanks. If I could just build on what Jane has said. The chief officers in Scotland have been considering this, and in different parts of the country directions are more or less used. So that is a building piece of work. But I just wanted to make a cultural reference, which is that we are in partnership with NHS Tayside and with Perth and Kinross Council. And directions, by the very word of it, can sound almost a little commanding, and that's not the intention. It is about having a clear process of communication with our partners when we consider the commissioning and planning responsibilities, decision-making responsibilities of the IJBs, and how that is then communicated back to our partner organisations. And it has to be done with respect, politely, and in consideration of the other pressures that are falling on our partner bodies, and not just unilaterally with the IJB in mind.
Thank you, Mr. Packham. Mrs. Bastard.
As an observation really in relation to point 2 of the Transforming Governance Action Plan, it's really to do with the induction of IJB members and refreshing that. I note that we're working with the Vice Chair of the IJB Board to develop that. I'm just really mindful of comments elsewhere in the document where in governance terms it says there's no uniformity across Tayside IJB and HSCP arrangements. I just wondered whether we could actually extend that to look at a more collaborative and integrated approach in terms of induction. We're one of 3 integrated joint boards, and I think there may be merits in some of that induction process being a shared process and shared understanding. And really I wondered what guidelines there were coming forward for induction through the public appointment process before members actually join an integrated joint board, and whether that could be fed into the overall induction process, both now and indeed going forward. Thank you.
Mrs. Smith.
I mean, I think the benefits of a collaborative approach are unquestionable. I think it would be very wise to look at what we can do. One thing, though, I would say is that the actual governance framework here in Perth and Kinross sits slightly differently, so that there are definitely nuances, but largely there are definitely, there's definitely an opportunity to look at this across Tayside. In terms of the guidance coming around the public appointments process, that's something I don't know, and it's something certainly we can follow up.
Thank you. Mr. Packham?
I think your point is very well made, Mrs. Best-Stewart. We're increasingly having to collaborate across the IJBs, and therefore the joined-up understanding of our board members will become increasingly important. I can give you a direct example in the bringing together of a mental health alliance for NHS Tayside, so that the issues that we face as the hosts of the inpatient services are directly connected to the community services in all three of the geographies of Tayside. And I agree with Jane that I think your point is well made, and I wonder whether we shouldn't lobby the public appointments group to see what we could bring to them.
I think in conversations with other colleagues as members of integrated joint boards, I think we would certainly welcome that going forward.
Thank you. Do you have any further questions or comments on the Transforming Governance action plan? No? Okay. We're asked to... Did you? No. Okay. Thanks, Councillor Drysdale. We're asked to note the progress of the Transforming Governance Action Plan 2018-19 and to remit the Chief Financial Officer to present a further update at the next meeting of the Audit and Performance Committee on further progress. Can we agree the report? Thank you. Moving on to item 5.3, which is the Chief Social Work Officer Annual Report. This has also been to Perth and Kinross Council in December last year, and it was put before the Integration Joint Board on Friday last week, and we had a rather good presentation from Mrs. Pepper, the Chief Social Work Officer, on this. But I'll ask Mr. Henderson to talk to the report. Thank you.
I mean, really, very briefly, to highlight. So this is one thing to say is that this is already a bit old, if you like, because it relates to 2017-18. So there's already been changes since then. So it's just to note that. But probably to highlight in terms of the IGB responsibilities in terms of the adult side, I think there's some really really wonderful examples of social work and social care support here. And maybe just highlight three instances, three areas I think the report touches on. I think first of all is the ability that's marked throughout the report to change and to transform services and to improve services. We touched on that in relation to the work around delayed discharges in the performance report for older people. But there's a number of areas throughout the report where there's been substantial change, particularly around to personalised services, or change around, say, the Carers Act and work that's been put into around that. So I think that really comes out very strongly in the report. The other aspect I want to touch on is around quality. I think the report shows high levels of quality, whether looking at our social work delivered provision in terms of day centres, care homes, supported living services, and other teams. We've got very high levels of care inspection grades with numerous very good and excellent results. And also in terms of our supporting people with very complex needs in the community through self-directed support, there's some really good best practice examples highlighted there. And lastly, in terms of our user care involvement, particularly getting communities involved, and I think there's some really wonderful examples of participatory budgeting highlighted in the report, throughout the report, and that's been done for carers as well. There was a participatory budgeting done. So I think that there's some really wonderful examples highlighted in the report. Again, it touches on the challenges of resources and legislative change, but I just want to highlight these three areas.
Thank you very much for that, Mr. Henderson. Do we have any questions on the report? I wanted to ask about the, in relation to self-directed support and the delegated authority that has been given in terms of approving budgets of certain levels. I think that's very interesting in terms of some of the things that the new Chief Executive of the Council has been talking about. in relation to think yes. So often problems in the past about policies and bureaucracy getting in the way of actually delivering services to people, and empowering staff to actually make those decisions can be really positive, both in terms of the outcomes for the individuals who are getting the services, but outcomes, does that go off? The outcomes for those the staff as well, because they feel that they're being given greater responsibility to make those decisions. So I suppose that obviously that requires a different governance and monitoring arrangement to ensure that, you know, that's not leading to significantly increased budgets and various other things like that. So I think that would be my first point about how that's being addressed. And then my second point would be, we've spoken a lot before about the different types of care options that are offered under the Carers Act, and the ability of people to look at options outside the ones that the council would offer in terms of community models. And we have the example in Highland Perthshire, the Care and Wellbeing Cooperative, and what's being done to encourage the use of those models. So those would be my two questions.
To start off the authorisation levels, we were quite quick to introduce various authorisation levels or bandings, whether you were a social worker, whether you were a team leader, or whether you're a service manager, but particularly around the workers. And we're constantly reviewing that, because as you say, there's a tension between giving people the ability to design packages of care, and you can see examples in the report where that's been done really well, but at the same time having an accountability level. I mean, in terms of the accountability, we've just recently set up what are called complex case panels in each locality. So these particularly just have been giving us oversight of some of the particularly for people with learning disabilities and mental health, where there's quite high budgets where they're using self-directed support, and it's using quite a lot of resources. And these panels basically oversee it, and they give a bit of comfort to social workers and team leaders to make sure that they are basically an oversight of that, to try and manage that. But the actual budget levels is something we constantly kind of look at to see whether we've got it right.
And just as I know you won't have the exact details to hand, but as an overall indication, because usually when models like this have been introduced, the fear would be that it would lead to much higher budgets, but actually where it's been introduced and used in housing associations, I think in Glasgow and various other parts, actually the budget has remained fairly static. So it seems to be a win-win situation. Do we know roughly what the impact has been in Perth and Kinross?
So we introduced it probably 4 or 3 years ago, and that was something we monitored, and there wasn't that increase that we were maybe anticipating, that we were concerned about. So we didn't see that. So a bit like you've said, that I think that's somehow something we think will happen, but that's not happened, particularly in terms of the care that's authorised by the social work level. Sorry, could you repeat it, Councillor?
That's all right. My second point was about the different models that are, the different options that are offered under the Carers Act. So in addition to the delivery through the council, that the council would offer also cooperative models and various other community models that can be used when people are choosing their own types of care, and what's being done to encourage the use of those models. Well, people have the choice, but not to. I think one of my concerns and concerns of colleagues has been in the past that when people are being asked to organise that care themselves, that can be quite scary, and actually that might be the right type of care for that individual. So what's been done to break down the barriers, I think.
Okay. Thank you, Councillor. So we've just recently published our short break statement, which outlines the types of short breaks that we provide excuse me, for carers. So, and if you look at the short break statement, it shows that we provide a huge range of short breaks or respite options that go well beyond your traditional types of respite from that would be considered residential care. And now there's a multiplicity of different respite options covered. And in relation to the community side and locality side and how carers can be supported through that, I mean, that has partly been done through the participatory budgeting models and the carers participatory budgeting that we've done. But we're also looking at broadening out our registered providers for carer services. So there's something called a registered provision if you want to provide carer services in the community. And we've recently increased that so that more innovative and kind of smaller business models can get involved as part of that, and so that they can be included and funded if the carer wants them to do that. It's certainly something we're looking at, particularly because the new carers legislation brings in a self-directed support for carers, so carers can design their own package in their own right through direct payments, etc. So that's something that's being promoted through teams. I guess with all of these things, it's about this awareness, not just within teams, but that's something, a continual awareness and training that we're doing within locality teams to get that out there. But also, I think, as you touched on, I think carers themselves need that awareness and need that confidence to be able to start thinking of these things and thinking, for want of a better phrase, out of the box about how they might be supported. But that's certainly something that's ongoing and is part of the new carers strategy locally that we're looking at.
Thank you. Do we have any further questions or comments on this report? No? Okay. Oh, Councillor Stewart.
Thanks, Chair. I don't have any questions. I think it's a really good report. I think it's also good because certainly what's very clear in the covering report to the actual report itself, the 5-page covering report, is that it pulls out itself that not only are we documenting within the body of the larger report itself that there are notable achievements that have been reached by the staff working in this area, but also that there are areas which need to improve. I think the recognition of areas, the self-recognition of areas for improvement is critical. So we've got lists of the key challenges that are faced and how those are translated into the strategic priorities for going ahead. I think it's a good example of where we have where staff have performed well and delivered services well, and those are documented, but also pulling out the areas for improvement in order to achieve a culture of continual improvement within the service. And I just wanted to put that on record.
Thank you for that, Councillor Stewart. It's certainly something that we've discussed at this committee before, that self-evaluation is extremely important, and it is always very useful to see that coming through reports to this committee, and we don't get any surprises when we find things out through inspections or other things. Okay, moving on to... sorry, I was doing the moving and then you had your other questions. So just to formally note the Chief Social Work Officer annual report. Can we agree this report? Thank you. If we now move on to the Finance and Audit section of today's meeting, and item 6.1 is the Audit Strategy, which is a report by KPMG, and we have Mr. Wilkie here from KPMG, and I'd like to invite him to introduce the report.
Thank you. Maybe just by way of introduction of myself before the report, I've taken over as engagement leader from Andy Shaw, having previously been involved in the audit of the Integration Joint Board in its year of inception, as well as Perth and Kinross Council, and before that a number of local authority-based entities as well as health organisations. I'll turn to our strategy, and I would intend just to talk to some of the key points, and I'll stop before we get to the appendices and take any questions. On page 3, just a summary, page 125 of the document, a summary of our responsibilities ultimately to issue an opinion on the financial statements, as well as some wider scope responsibilities that we have under Audit Scotland's Code of Practice, primarily focused on wider scope objectives. So that includes consideration of things such as financial sustainability and management, value for money and governance, all of which we've spoken about today, and no surprises are included within our audit strategy as areas we'll consider and report on in due course. If I go over the headlines just to go into the detail of the report, on page 128 we've set out our approach to materiality, and that's consistent with the basis that we've taken in previous years and in terms of the percentage applied. So overall, based on 1% of gross expenditure being just under £2 million. We use that as the threshold to design our procedures, and we design the procedures to detect errors below that amount, and in fact would report anything above the reporting threshold, just under £100,000, back to this committee. That's not to say that errors below that would necessarily not be reported if we think that maybe by their nature they're worthy of reporting nonetheless. On page 129 we have two significant risks. These are risks which are presumed by audit standards to exist in any audit unless we rebut them. And worthwhile just noting that the first one, which is management's unique ability by their position to be able to potentially override controls we accept as a risk, and we design procedures to address that risk. And the second, around the risk of income and expenditure recognition being manipulated, is again presumed, expenditure recognition being presumed for not-for-profit bodies. And we have in both cases rebutted that risk also, on the basis that we think there is limited judgment and opportunity to reflect income and expenditure in a year other than that in which it genuinely has been received or incurred. And that's down to the way the transactions are ultimately reported by the partner bodies into the Integration Joint Board. If I move on to page 8, we have some other focus areas, so not significant risks, but areas which we nonetheless think are worthy of drawing your attention to in our strategy, and which we'll ultimately report on in our annual report. And that's the completeness and accuracy of expenditure, linking to the fact that it is being reported by partner bodies, and also financial sustainability, recognising the challenge that is faced in terms of medium and longer term financial planning. Perhaps the other part of our report I'll turn to just before finishing and taking questions is from page 134 onwards, and that's our approach to wider scope areas. The pages before that summarise how we identify them, and will address them throughout the audit. We haven't particularly identified any significant wider scope risks, so these are just focus areas, and they're consistent with things that we've spoken about today already. So financial sustainability, demand pressures and transformation. We will consider what the IGB is doing in terms of progressing its developments and arrangements in that respect. And then on page 136, areas which largely are indicated to us by Audit Scotland planning guidance, which we're expected to consider across all our audits. So things like EU withdrawal, the impact and planning arrangements that the body is undertaking, and touching there on dependency on key suppliers. And I do take the point in context of the commissioning arrangement that exists, but it's an area that we will update on in our annual report. And then lastly, on page 137, we will look to update on governance arrangements and developments, as we've spoken about, are continuing to be enhanced, and on value for money arrangements. In terms of the appendices, that just includes mandatory communications we're required to make under auditing standards, including confirmation that KPMG and myself personally are independent. I would just probably stop there, and happy to take any questions.
Thank you, Mr. Wilkie. If I could first ask about the financial sustainability points on page 8, which are also referenced on page 13. It says that about the risk-sharing agreement, that the agreement stipulates from 2018-19 any overspends by the board may be funded by NHS Tayside and Perth and Kinross Council based on each body's proportionate contribution in the financial year, or by the body with operational responsibility as a default position. This gives the board comfort with regards to overspend. I think the issue here, and this was raised at the board, and there was a formal resolution of the board with regard to this on Friday last week, was that while that is the correct position in the integration scheme, we have had discussion about reviewing the risk-sharing agreement, and while we have a situation where overspends may be allocated on the basis of the proportionate contribution, what we are looking for as a board is certainty as to what the risk-sharing agreement will be. The Council and the NHS Tayside Board have two options there now from the third year of the IGB. They may decide that they want to continue with the current option, and that's a matter for them, not for us. But until such a time as we have certainty and clarity on that, I'm not sure the fact that the integration scheme outlines two options provides us comfort when we don't know, the parent bodies haven't given us assurance as to what the risk-sharing arrangements would be. So I think it's more just in terms of the phrasing of that, but it is quite important in terms of, I think, how we as board members feel, and that was articulated at the board on Friday last week. So just if maybe that could be updated to reflect that.
Thank you. I appreciate your point, and we had worded it specifically to reflect what is in the agreement, but fully understanding the point you make.
Thank you. Do we have any further questions for Mr. Wilkie? No? Any comments? Okay, thank you very much. Thank you for that. If we now move on to item 6.2, which is the Internal Audit Progress Report, which we have at each meeting of the Audit and Performance Committee. Mr. Gaskin has given his apologies today, so I'll ask Mr. Hudson to introduce the report. Thank you.
Okay, thank you, Chair. So the purpose of this report is just to provide the committee with progress in relation to the current internal audit plan. Field work on the 17-18 work is substantially completed, and with reports currently being drafted. These reports will be presented to the next committee meeting, which I believe is in June, and work on the 18-19 plan is currently ongoing. I noted your earlier discussions around the performance management information, etc., that's been provided to this committee, and we do have a review under the heading PK 0519, and we will certainly be taking on board some of the comments that were made today within that audit. I don't actually have anything else to say at the precise moment. Just happy to take any questions.
Okay, thank you very much. Do we have any questions on this report? Any comments? Okay, well, yes. Yes, that's, we don't need you for the next one, do we? No, okay, right, that's fine. Okay, no problem at all. We are asked to note the substantial completion of the 2017-18 internal audit plan, as well as the commencement of delivery of the 2018-19 plan as outlined in the report. Can we agree the report? Thank you. Moving on to item 6.3, which is the audit recommendations update. I think one thing just to note, as you will know, as part of our refresh of the governance arrangements and the terms of reference both of this committee and the wider IJB as a whole, that as we now have the Clinical Care and Professional Governance Committee, which will be starting at some point in the very near future, which will be chaired by Councillor Stewart, the Vice Chair of the IJB, that all actions in relation to clinical care and professional governance will now be tracked and monitored through this committee following this report today. But I shall now pass on to Mrs. Smith to introduce this report.
Thank you, Chair. The audit recommendations update is in line with best practice in bringing to the Audit Performance Committee a robust update in terms of our management actions that have been agreed in response to findings of both external and internal audit reports. This, I think, is now the second report that we've brought forward in this regard. It's now been updated for any internal or external audits that have been concluded since the last report. we can indicate a level of progress. There are some items that are overdue. It is worth noting that we have taken opportunity to review and revise the timescales, recognising that some of the timescales that were accepted by management at the time or agreed by management at the time have been too challenging. I think a number of those are in relation to clinical care governance, and I think as part of the clinical care governance's transition to take over these recommendations, we'll want to make sure that the timescales for these in particular are in line with the priorities of that new board. There is quite a lot of detail in the report. I don't plan to go through it recommendation by recommendation, but I'm happy to take any questions.
Thank you, Mrs. Smith. Do any members of the committee have questions on this report? Any comments? Mrs. Burstewart.
I have one comment relating to the care governance. It's an observation, really. I don't know whether this is the point at which I should bring this forward, and if it isn't, I can bring it forward. But it's to do with the governance good practice in relation to membership of the subcommittees, where there might be a conflict, where a member might be chair of the parent body at NHS Tayside. So, for example, anyone who was the chair of the Care Governance Committee here, if they were also chair of the Care Governance Committee of NHS Tayside, that could be perceived as marking your own homework, and therefore I think clear blue water, and that would be reflected going forward in terms of membership of the Integrated Joint Board subcommittees from NHS Tayside, that we will endeavour to ensure that there isn't that conflict and position members appropriately going forward.
And I think now that we have, once we have the new members from NHS Tayside in terms of the IGB, and then we have some stability, and we were looking at having, of the 4 members from each parent body, 2 would sit on each. And as you're now a member of the Audit and Performance Committee, then perhaps the new member from NHS Tayside could sit as one of the members on the Clinical Care and Professional Governance Committee. Mr. Packham?
Thank you, Chair. It's just to reinforce the point that Mrs. Burstewart has brought forward. This issue has also been raised by the Professional Head of Nursing in concern to make sure that there is no duplication of role across all of the different layers of governance. So I am working with others at the moment in order to clarify who is sitting on which committee, in order that Councillor Stewart, when he is leading this, will have a clear indication of what the membership should be.
Thank you very much. Mrs. Burstewart, did you want to? No? Okay. Any further comments? Nope. We are asked to note progress made to date on implementing the agreed recommendations as part of the audit recommendations. Okay. Thank you very much. We shall move on now on to item 6.4, which is the 2018-19 financial position. Now, this report has been to the Integration Joint Board on Friday last week, but the Audit and Performance Committee does have a role to oversee the financial position of the IJB, so it is coming here, but we do know that it was only a few days ago that committee members have seen this, so there may not be any additional questions, but Mrs. Smith to introduce the report.
Thank you, Chair. The report highlights a projected overspend for Perth and Kinross Integration Joint Board based on the 9 months actual expenditure of 1.954 million. This is a significant improvement from the last report. The last report to the IJB forecast a £4.4 million overspend. A significant element of that improvement relates to our recovery plan actions that have been identified at the IJB on Friday. The members approved, or rather homologated, the financial recovery plan that sets out £1.2 million worth of recovery plan actions. So within the overall improvement of the position, those recovery actions are factored in. We are forecasting that they will be delivered, and not clearly there remains some risk attached to that. Over and above that, we have a number of underlying improvements to the financial forecast. Firstly, in relation to GP prescribing, an overall improvement of around about £250,000. As members will be aware, prescribing is notoriously difficult to predict and can move greatly from one month to the next. So we watch and wait to see what happens between now and the year end. Another area of underlying improvement relates to complex care packages. That is a clear action in the financial recovery plan, but over and above that, we have seen an underlying improvement in terms of the overall costs of complex care packages forecast to the year end. Finally, in relation to health, our health, elderly, hospital and community services, the work that we've done as we move towards the year end to consider whether posts will be filled across a number of key areas has identified a level of slippage that we've now built into the financial forecast. We continue to work hard to ensure that all possible options are taken to minimise the forecast overspend that remains, recognising that that overspend in line with the risk-sharing agreement, once they're agreed, will fall to our parent bodies.
Thank you, Mrs Smith. Do we have any questions on the report? Any? Councillor McDade.
It's not really a question, it was more just to, it was really a comment around the fact that we have recovered significantly from the previously reported position. I think that needs to be recognised as not an insignificant recovery as well. I think the last meeting in the IGB was about November time, so from November to early February to recover a position of 4 down to 2, and when you're talking about millions, is quite significant, and that is something to, be recognised.
Thank you, Councillor McDade. Any further comments? Okay, we are asked to note the overall projected overspend of 1.954 million for Perth and Kinross IGB for 2018-19, an improvement of 2.081 million from the last report, as Councillor McDade has just alluded to. To note that a separate paper on the 2018-19 financial recovery plan agreed by NHS Tayside and Perth and Kinross Council was brought forward to the IGB for homologation, as Mrs Smith has alluded to. This plan includes 1.238 million of recovery plan actions, which are assumed to be delivered within this revised year-end forecast. To note progress with the 2018 savings delivery, and to note the update regarding IGB reserves. Can we agree the report? Thank you. Moving on to item 6.5, which is the Audit Scotland report, Health and Social Care update on progress. Mr Packham, if you would like to speak to this report, please.
Thank you, Chair. This paper was again presented at the IJB on Friday, and I would just like to briefly introduce the fact that this paper has brought to the attention of the nation the progress that is being made in health and social care integration. This document ought to be read alongside a more recently published document for the Ministerial Steering Strategic Group, looking at, again, the recommendations that have come on progress in integration. There are common themes amongst the two documents. And finally, I think it needs to be connected with the new strategic plan that we're currently working on for Perth and Kinross Health and Social Care Partnership. The underlying themes in this report are noting the changes that are already happening in the strategic shift of services, people who are seeing more services delivered in their own communities. It makes recommendations not only for IJBs but for their partner organisations in terms of their financial situation and the pressures that exist across health and care services, and the need for integration authorities to make meaningful change, but this is an interdependency with the two partner agencies. There's reference also to the barriers that have been identified in terms of pace of change, and we are fortunate here in Tayside to have very positive collaborative working relationships. However, these things can always improve. We see reference to turnover in membership of boards, and we here in Perth and Kinross have experienced quite a significant change over in our board membership. However, it has to be said that the team that has been working operationally has remained relatively static, which is a privilege in comparison to some other areas. Finally, the report talks about culture and the way in which all partners need to align themselves around the purpose of health and social care integration. This is a well-supported policy, both from COSLA and the Scottish Government, and we have been given indications recently that the purposes of integration are here for the long term, and this is really an indication that all players, professions, organisations and partners should be aligned around a common purpose. I'd be very happy to respond to any questions, but this document, I think, is a fair reflection of where we are on the integration journey.
If I could just make a comment and a question first. I think it was quite interesting, some of the things that we have spoken about in the past about the financial resources and support services to the IGB that is reflected across IGBs across Scotland, that there isn't sufficient support in those two areas. And I think that we have all acknowledged and experienced that, and that's certainly something that we have to address. Following on, I suppose, from the discussion about the risk-sharing agreement, the thing that interested me was about reserves and the different position across Scotland in terms of the level of reserves that IGBs have. You know, we do have a reserve policy, but obviously we don't have any reserves. Now, in terms of the level of reserves, it seems that some is generated, the vast majority is generated through underspend, so clearly the budgeted position is higher than they're actually needing to spend, and that's generating that amount of money. But in some cases, are authorities asking, are integration joint boards asking their parent bodies for more than they need in order to build up reserves? Or is that explicitly included in the budget? Because I suppose that you know, having some reserves is a good position to be in, particularly given the as we've talked about, the uncertainty in terms of GP prescribing, demand pressures. We're never going to get the forecasting exactly right. So having a cushion is quite helpful. But if we're in a situation where we're always asking for exactly what we require, so we aren't building up, we're never going to be in the situation where we're going to build up as an integration joint board, not as a parent bodies, our own reserves. So we'll always be relying, in the case of underspends, on any risk-sharing agreement, whatever that may be. So first, just do we know what's happening in other areas, other integration joint boards, and has there been any thinking done in terms of ourselves about what our strategy should be? We have the policy, but what's the reserve strategy?
I think it's a really interesting question, and it does make for very interesting reading. And I think members will know of our own history around reserves, which has been that, you know, despite a very significant underspend on social care in the previous financial year, that was pulled back by Perth and Kinross Council and passed back to us as part of our settlement. So that very significant opportunity that we've had as an IGB to retain unearmarked reserves, to provide a cushion to the unanticipated pressures that we've seen this year, has left us exposed, and we will continue now to have that level of exposure. In terms of other IGBs, those who have, like us, had underspends that have been able to retain, that will be reported in the position. Earmarked reserves, we, again, a slightly unusual position in Tayside, where, and I just need to be careful how I explain this, NHS Tayside's treatment of carry forward has meant that we as an IGB have had not had up until now any earmarked reserves to carry forward. NHS Tayside have done that on our behalf. What we'll find for the first time this year is we will retain our own earmarked reserves. It's set out in the finance report, so it will give us a level of reserve that other IGBs may be themselves carrying forward, that will, but it does not provide us with the cushion that we would want to see. So there's been those two situations for us that have made us sit slightly apart. One of those will be addressed, and we will now carry forward our own earmarked reserves.
Do we know, in terms of the situation that we had previously, whereby the council, the underspend on the council side was retained by the council and then passed back to us in a settlement, whereas in other areas that underspend has clearly been retained by the IGBs? Do we know if that's a difference in terms of the integration schemes across Scotland, or has that come about through mutual agreement between the Integration Joint Board in that area and the parent bodies? Or if we don't, is that something that we could find out?
I think it would be difficult to find out the different sort of tapestries that each IGB are living and breathing, and a lot of it does come down to the collaborative nature of relationships. And unfortunately, you know, almost up until now, and we've kind of celebrated the fact that we're benefiting from the strengthened relationships between NHS Tayside and Perth and Kinross, and that will can only support our aims further. But our history, the last 3 years, that has not been the case, and those collaborative discussions did not enable us to retain reserves that we otherwise might have done. But certainly, I'm not sure that we would be able to bring to the table formally a detailed knowledge of the historic nature of other IGB's reserves. There is work being done across Scotland in the CFO network that may provide some insights, but not at a detailed level, IGB by IGB, and I'd be happy to bring that back if it was available.
Okay, yeah, that additional information would be useful, I think. Councillor McDade, you had a question.
Yeah, I was just going to pick up on Rob's point. I thought getting before Eric did, because this is one of Eric's favourite points about the magic merry-go-round, and just to make the point about that we have now had a reasonably stable board membership since May. Well, we have had a stable one since May, pretty much, and that once we have our full complement of new members from NHS Tayside, that should be us as a stable 8 voting members, hopefully, touch wood, for a significant period of time. And I think what I said on Friday, I'll just reiterate it now, that I think in terms of the strategic direction, there is a lot more shared vision between the current board members, both council side and NHS side. I think that's a very positive and important thing, because it's not just in terms of officer relationships at the NHS and the council, but actually around the board having that shared vision as well. And I think we are getting to the stage where we actually have that, where I think that has been severely lacking in the past, potentially. I would say, having been through a number of different compositions of this board, I would say that has been lacking. So I just think it's important that we actually make that point, since this is audit and performance, about in terms of basically performing our function. I think we are actually now in a place where we are performing that function significantly better than we were before. So I just wanted to put that on the official record.
Having been through a number of iterations and unwanted absence as well. Mr. Packham.
So, thank you for that, Councillor McDade. I mean, I think within every cloud there's a silver lining. And for us, as we've reflected on this, not only does the change in membership bring some challenges around, you know, the repeated iterations of induction, for example, but it also brings the strength of a lot of different experience to this board. And in the 4 chairs we've had differences in each of our 4 chairs, and they've each brought strength. And similarly in the membership of the board, there's been different challenge brought to us as an IJB simply because of the life experience and the roles of the people who have contributed to this board.
Thank you. Do we have any further questions or comments on this report? Okay, if we move on to the recommendations, I would like to add an additional recommendation. If I can find my bit of paper. Apologies. Right, it is recommended that the Audit and Performance Committee notes the recommendations contained in the report, considers which areas highlighted should be reviewed with partner agencies. We've given some indication. Notes that the IJB management team will review this document via its executive management team by means of a self-assessment exercise on progress set against the Audit Scotland report recommendations. Just like to say first that if anyone on this committee has any further comments that they'd like to pass on to Rob, to Mr. Packham, apologies, or anyone else when they're doing this work to look at those recommendations, then I'm sure that that would be welcome. I'd also like to ask that once the IGB management team has reviewed this document, and our progress in terms of the self-assessment exercise against the Audit Scotland recommendations, that if that work could then come back to the Audit and Performance Committee for our review. Mrs Smith.
It's just two things there. What we haven't brought forward today is the Ministerial Steering Group paper that has also been issued, or we're coming on to that, sorry. I think because both contain a significant number of recommendations, it may be that we kind of look at them jointly. The only thing I would say is there are so many where we're kind of reliant on working with our parent bodies to consider how best to take that forward. It'd be difficult for us around this committee to commit to a kind of time scale to that, and any time scale would need to be agreed as part of a wider process.
Mr Packham.
Thank you. Yesterday I spent some time with colleagues in NHS Tayside talking about the strategic plan and looking at aligning the strategic plan that's coming from NHS Tayside with the 3 IJBs in Tayside. There is definitely a different culture around collaboration, and in fact it appears to me that NHS Tayside is working very hard to build on the work that's been done in the 3 IJBs to make sure we have coherent pathways of care across Tayside. In the same vein, I have been working with Karen and the Executive Officer team here in the Council, because we've talked today already about the interdependency of complex care on housing solutions, and similarly in through care, as we start looking at the pathways of care that will move perhaps to the Clinical Governance Committee, but we need to think about the impact of education and children's services in our role around anticipation, prevention, early intervention. Just as a basic statistic for the ears of this committee, the majority of mental health issues appear in children between the ages of 14 up to the age of 24. If we don't connect our services with children's services, then obviously we have an impact on our adult services. Forgive me. Go on.
Thank you, Mr Packham, and also for committee members to note Appendix 2 of Report 6.5, which sets us out a format for the self-assessment review, and that would probably be a useful document to come back to us. So can we agree the report? Thank you. If we just move on now, finally, to items for information or noting. The item 7.1 is the Audit and Performance Committee revised terms of reference, which we approved as our formal recommendation to the Integration Joint Board at our last meeting, and then was approved at the Integration Joint Board meeting before last. So that's just coming back for information. We also have the Audit Scotland Perth and Kinross IGB Annual Audit Report, a letter to Mr Packham. Would you like to just quickly give a summary of this item 7.2?
So the feedback here comments on our good working papers to support our annual accounts. I must pay credit to Jane and the team for the incredible work that they do in containing what is a very complicated set of accounts for the board. It looks again at the 3 recommendations in relation to the timeliness of financial monitoring, the approach for overspend and a risk-sharing agreement, and the development of a workforce plan. I'm pleased to see that we're agreed to implementing these recommendations. Obviously, this is work ongoing. And finally, obviously, it's acknowledging the degree of pressure that's been illustrated by our financial reporting today. We've talked briefly about the amount of work that the partnership has had to do, a relatively small number of people with a fairly wide range of responsibilities. And obviously, we've spoken briefly about the changes in board membership. I think I can really just leave it at that. I mean, if there are any comments or questions from members, I'd be happy to try and respond. Thank you.
Okay, thank you, Mr Packham. Any comments or questions on that? No? Can we note the report? And finally, we have item 7.3, which, as referenced before, is the Ministerial Strategic Group for Health and Community Care, their review of progress with integration of health and social care, the final report. This was touched on at the Integration Joint Board meeting on Friday, and also in the private briefing session beforehand. There's just a couple of points that I would raise. As Mrs Smith has quite rightly indicated, that it's important that we look at this in parallel with the report from Audit Scotland, and also in partnership with our parent bodies. The Chief Executive of the Council made reference to on page 254.23, the delegated hospital budgets and set-aside requirements must be fully implemented, and there was talk about the 50% reinvestment in community to sustain improvement, and she indicated that she and the Chief Executive of NHS Tayside would be having further discussions about that, and with IJB officers about how we can progress that. Also, there is, as we've discussed before, about the recommendations of clear directions that must be provided by the IJBs to the health boards and local authorities, and we've also asked earlier on in this committee for further information on that, and I think that's really important to give board members the assurance that we need in order to challenge and scrutinise any directions or not that are put forward in any reports. I'd just like to say we'll come on to the recommendations in a moment, but if we can tie that together with our previous agreement that the self-assessment of both documents, following on from both documents, will come back to the Audit and Performance Committee once that work has been completed. Do we have any questions or comments on this report? Mr. Packham?
I'll just make a brief comment. These two documents are extremely helpful to us as an IJB. It creates a level of energy around some of the things that we've identified that need to change in terms of our relationship, our effective working relationships with our parent bodies, but also internally. And some of the significant challenges that are set out are also dependent upon engaging with our clinicians, our professionals, to make sure that the change that is required can happen at pace. So, for example, as we're talking to GPs or to consultants, or if we're having discussions with partner agencies, there is a great deal of coherence now around the purpose and the aims of the integration legislation, and I think it's set out extremely well in the diagram that's on page 252 or page 6 of this report, and showing the interdependency of all these different elements that require our energies to gain further success.
Thank you, Mr. Packham. Well, if there are no further comments, just to run through the recommendations, we're asked to note the proposals contained in the report. We've also said that there's an open invitation for board members to highlight any areas that they would like officers to consider to Mr. Packham. To note that the IGB Executive Management Team will develop key actions set against the proposals within the document. We've also talked about this will be done in parallel with the Audit Scotland report, and that further work will come back to this committee. Are we happy, therefore, to agree this report? Okay, thank you. That concludes the public session of the Audit and Performance meeting today. Our next session will be on Thursday, the 20th of June, at 9:30. Thank you to all members, and thank you in particular to the non-members of this committee who have taken up my open offer to attend and to assist with the questioning today. Mrs. Burstewart.
Yes, just with regards to the Thursday, the 20th of June, I need to flag up that all the non-executive members from Perth and from NHS Tayside would be unable to attend that meeting. It is in the corporate diary. It's a clash with the Board of Trustees meeting, which all non-executive members are required to attend. So none of us would be able to attend. So could that be reflected in the meeting schedule?
I think that's an important consideration, and perhaps not a good reflection on joint working, but we'll seek to address that. Okay, thank you very much for your attendance.